contract was awarded to two service providers, bos310amb for the newly formed East Zone and American Legion Ambulance for the, newly formed North and South Zones. Those agreements end this June 30th, 2010, and there was a clause in the contracts that said that they would be renewable for an additional 5-year period if the providers met all their performance criteria. The purpose of this report is to provide an evaluation of the performance during that first contract period to see if indeed those providers are eligible for renewal, provide recommendation on renewal based upon that performance, and then provide recommended revisions to the ambulance agreements for the second 5-year contract period. The process that we went through in renewing these, first of all, we had to confirm with the providers their willingness to renew. Once that was confirmed, review the performance of the providers to see, again, if they were eligible for renewal. Once that was determined, to negotiate terms of the second agreement, and this was really a first phase negotiation between the EMS agency and the ambulance service providers themselves. Once we had drafted those, we solicited public comment on those agreements. Then the revised agreements went to the EMS OC for review and approval. Now we are making the presentation to the Board of Supervisors, and final approval by our EMS board is scheduled for April. Just to go through each one of those, confirm providers' willingness to renew. We sent letters to each of the providers in July 2008. And the reason we sent them that early was if we got a response that they were not willing to renew, we would have had to gone through a competitive bid process again to maintain the exclusive operating areas, and that would have given us enough time, maybe enough time to go through that competitive bid process. We did receive affirmative responses from both providers by the fall of 2008 that they were willing to renew. Based upon that fact, we went into the performance evaluation during the first contract period, and there's actually, and you can see in the report, there was several categories that we looked at, but these were some of the highlights. The inspections that had been done periodically throughout the contract period, vehicles and equipment were consistently found to be of the highest standard and continually maintained at that standard. Field personnel qualifications and training requirements for both providers often exceeded contractual requirements. Level of care, there was no significant issues. As a matter of fact, the level of care that's provided by the field personnel here really has been exemplary. And their internal quality improvement programs were found to be in compliance and often exceeded our requirements for quality improvement. So the last major category that we had here was response time standards as established by the EMSOC were met during that contract period. There were some minor contractual issues identified with both ALA and Evans Pass Fire District during the initial contract period. However, these issues, when they were brought to the attention of the providers, were quickly and professionally resolved. There was no occurrences of any major breach during the period, and providers were found, based upon that, to be eligible to renew the agreements. And again, a detailed summary of the evaluation of both providers is in your packet. Once it was determined that the providers were eligible to renew the contracts, we began negotiations between the EMS agency and the providers as this first phase. And there was several minor changes made. Language specific to the initial contract period was removed. New changes in state regulations and definitions were made. Definitions of terms not utilized in the agreement were removed. Updates were made to be consistent with new processes for data submission that had been established after the initial contract. And probably the only significant change that we proposed during this first phase was that a requirement that had been placed in the initial contract that the providers after a period of time, meet CAS accreditation, which is Commission on Ambulance Accreditation. This is a national standard, and it is really the standard, the Cadillac standard for ambulance services, and that was actually a requirement in the RFP when that went out. Both providers attempted to go through that process, and it appeared they met all of the criteria. However, they could not meet the CAS accreditation because our internal communication structure within the county was not up to the standard that would allow them to be accredited. Because that was out of their scope of control, we were recommending that that be removed for the second contract period. After those initial changes had been made, we went out to solicit for public input on those agreements. We advertised in local newspapers. Complete packets of all the available materials were available at local fire departments, public health department, and on the Mountain Valley EMSA website. A public meeting was held on January 21st to solicit those public comments, and both the verbal comments from that meeting as well as written comments received after that meeting were integrated into the process. Based upon the comments that we received, there were additional changes made to the agreements. Language was added, and these are some of the minor changes that I want to go over first, but language was added to allow continuation of the agreements in the event that there was some change in any of the principles. In other words, if the EMS agency changed, or if the dispatch center for some reason changed, we didn't want we wanted the contracts to be ongoing, so those were changed to be more generic. There was some clarification language was made because on critical care transport units and response times for those. A recommendation was made to require the providers to have a written agreement with the dispatch center prior to execution of the ambulance provider agreements. Those are some of the minor issues. The major issues that really came out during the public hearing, there was a call from the public and even some of the members of the board regarding the public-private partnerships. Actually, we had seen one during the first contract period. ALA had entered into a public-private partnership with Copperopolis Fire Department, and it was thought that that could be a model for other areas in the county. And even though the current contracts did not prohibit that in any way, there was no language in there really to encourage it either. There were several issues regarding response times. Some of those were based upon, I think, some misconceptions out there, but it brought up some issues regarding response times that we felt should be added. And then there was the issue of approval of rates, and we'll get into those. The language was added to the agreements to encourage the public-private partnerships if a potential partnership would enhance system coverage and response time in performance. Again, I think all of the providers, the EMS agency certainly was in support of that. The agreements that are currently in place did not prohibit it, but this just sort of strengthens that to add some encouraging language. Language was added specifically that all calls exceeding a predetermined response time, and again, this came out of the response time discussion. If there was a long call, right now the only way that we get flagged for that is if fire service or a member of the public brings that to our attention, we would look into it. There was no automatic look into any extended calls. So language was added to specify that all calls exceeding a predetermined response time would automatically trigger a quality improvement review by the provider and the EMS agency, and that a summary of the findings would be submitted to the EMSOC on a regular basis. Finally, a recommendation was made to have ambulance rate increases approved by the agency's board of directors instead of the Calaveras Board of Supervisors, since both providers provide service in more than just a single county. Again, the problem came up with having one board approved a rate change, and having multiple rates in different counties was problematic. So this was the initial recommendation that came out of those meetings. There was a change to this that we'll see a little later on. Some of the questions and the misconceptions identified regarding the response times, and again, I think there was quite a bit of time spent on this at the public hearing, but some of the questions were, how does the 90th percentile work? It's a little confusing to some people. Can providers bank calls? In other words, can they have a lot of short calls and get to be late to calls down the road somehow? And then I hear that there's been a number of response times over 1 hour. Is that true? And so these were some of the things that Marilyn is going to address as we address them with the MSSC.
Good morning. I'm Marilyn Smith, the Response and Transport Coordinator with the Mountain Valley EMS Agency. As Steve said, I'm going to talk to you a little bit about response time compliance. Contractually, the ambulance providers are required to meet their response time standards at the 90th percentile, which means in 90% of the time for 9 out of 10 calls. So again, we're going to go through and talk about that. For the purposes of this example, I made the assumption that the ambulance provider is contractually obligated to be there 15 minutes, in 15 minutes. Using all emergency calls that occur during the reporting period, I take all of those calls and you subtract the time that they're dispatched till the time they get on scene. That is what equals response time. So here, for my example, I have 10 theoretical calls that occurred in February, and you'll see that there's a time of dispatch time on scene and the response time, and that's a factor of subtracting the time dispatched from the time on scene gives you 10 minutes for that first call. What we then do is take those calls and rank them in order of response time, from the quickest call, the 1 minute call, to the longest call, which is 18 minutes. Then we look at the 90th percentile. In this case, there happened to be 10 calls I was looking at. And so you look for the 90th percentile, again would be the 9th call, and they met their contractual obligation because they were there in 14 minutes. Again, using the 90th percentile with the assumption that their contractual obligation is 15 minutes. And then there was a lot of discussion amongst people at the public hearing, and a lot of the comments that we got on the proposed changes to the contract regarding the banking of time. And so I wanted to give you a little explanation of banking of time and why that doesn't work. So, can a provider bank time? So if you look at this, using the same 10 calls that we used before, you look at their response times, and they added all up in there. So I took the bank time. First call, they should have been that they had 15 minutes to get there, but it took them a minute, so they banked 14 minutes. They banked all this. The last call was 3 minutes over the time, so we subtract that, and they, in theory, have put 69 minutes in a savings account to take care of long calls. But if you rank those calls, hold on. How do I go backwards?
No, that's it.
Oh, that's the right next one? So I, again, ranked those calls, looked at long times, and then in this scenario, they banked 102 calls. But if you rank all those long calls, if you notice from my previous slide, there were eight calls that they got there in a minute. And that was the assumption made by a lot of people that they could bank all those minutes. And then the 9th call was done at 14 minutes, and the 10th call at 18 minutes. But again, you look at the 90th percentile for the 9th call, it's still at that 14 minutes. And so, therefore, that 69 or 102 minutes that they saved by being quick on these other calls doesn't do them any good. So you can't look at averages, you can't look at banking of time. It's all done on 90th percentile, 90% of the time. And that's the standard that is used in the ambulance industry nationwide. There were also a lot of comments that there were long calls. So I took a look at each of the zones. The East Zone, which is served by Evans Pass Fire, and the North and South Zones, which are covered by American Legion Ambulance. And for the purposes of my study, I looked at data from July 2006, which is when their contractual obligations were established for their response time criteria, through November of 2009, which is when I really started doing a lot of this data reporting for this process. So that gave me 41 months to look at. In the East Zone, they ran 2,008 calls in that 41-month period. Their response time criteria in the East Zone, again served by this pass, is 13 minutes. They had 81 calls in excess of 13 minutes, which is 4.03% of their overall call volume, and they had no calls over 60 minutes. And so I broke down for you here the length of the long calls, and because the call took 50 minutes, for example, that's not a bad thing. It could have been way down into the river area outside. If you go through Dorrington and down through Big Trees Village and get down the river, it just takes that long to get there. That's okay, because the contractual obligation, you factor that in when you establish response time criteria, and again, that was established to be at 13 minutes, 90% of the time. In the East Zone, their 90th percentile compliance over the 41-month period was at 12 minutes. Their actual compliance was at 95.9%, and their average response time was 5.75 minutes. In the North Zone, in that same 41-month period, they ran 4,906 calls. Their contractual obligation in a much bigger zone is 20 minutes. They had 392 calls in excess of that 20 minutes, which was 8% of their overall call volume. And they had, in that 41-month period, over one call in excess of 60 minutes. And that call was in 72 minutes, and it was in the winter, way out in the West Plain area. Yeah. So weather was a factor getting out there, and quite a distance to respond to. Again, looking at the calls that were greater than the 20 minutes in the East Zone, the 392, you can see that the next longest one was at 55 minutes, and then there's several in the 21, 22, 23-minute range, for example, and you would expect to see those kinds of numbers occurring. In the North Zone, again for that 41-month period, their actual 90th percentile compliance was at 20 minutes. Their actual compliance was at 92%, and their average response time was 10.25 minutes. In the South Zone, also served by American Legion Ambulance, in that 41-month period, they ran 2,283 calls. They had 227 calls in excess of 20 minutes, and that was 9.94% of their overall call volume. And they had one call over 60 minutes, and that was one call that was 65 minutes, and that was in the wilderness area on the backside of Hogan Reservoir. And then looking at the rest of the long calls in the South Zone, the next longest call was at 45 minutes, and again you see several in the 21, 22, and 23-minute range. Again, contractually they're obligated to be there 90% of the time in 20 minutes. In the South Zone, their 90th percentile compliance was at 20 minutes. Their actual compliance was at 90.1%, and their average response time was 11.2 minutes. And then there was a lot of discussion about the Copperopolis area and the South Zone. And the South Zone was designed with Copper Fire in mind because they do provide ALS first response services. That's something that none of the other areas in Calaveras County have. And so I wanted to take a look at what was the response time into the Copperopolis area by Copper Fire. And we looked at it for 2008 and 2009. Their 90th percentile time in 2008 was 11 minutes, and their average response time was 6.44 minutes. And in 2009, their 90th percentile time was 10 minutes, and response time was 5.25 minutes. This is key because what you're really concerned with is the arrival of ALS intervention, and Copper Fire was being able to do that in a rapid manner. And that was one of the big discussions throughout this removal process was the response times in the far reaches of the South Zone. And that concludes my presentation about response times in the 90th percentile compliance.
Alrighty. My name is Peter Michaels. I represent District 5 on the EMSOC. and had the pleasure of being on the MSOC since all this fun began back in 04-05 time period. I'm currently the chair of the EMSOC. And I'm just going to talk a little bit about the process that the EMSOC took throughout this approval process and how we came up with our recommendations. As Steve mentioned, we held a meeting on the 21st to elicit public comment. And the week after that, we held our regular EMSOC board meeting on February 25th, where we reviewed all the public comments that we received and took each of those comments individually and considered how we would address those within the contract. We took the EMS agency's recommended response to each public comment and each of the board members' response to the comment into consideration. And then out of that committee, the EMSOC made the final recommendation. So during that meeting, we made the following recommendations. First of all, that we accept all the recommendations of the EMS agency staff with a few minor exceptions. Number one has to do with the ambulance rate schedule. We came up with a process where the ambulance companies could still address their own rate schedule to a certain degree. And so you can see here where we came up with a 3-tier process to allow providers, tier 1, to annually increase their fees to a set percentile without agency approval. Tier 2 would identify a percentile increase that would require the approval of the Mountain Valley EMS Agency Board of Directors. And then Tier 3 would require any increase beyond the second tier, so higher than the Tier 2 increase would require the approval of the county board supervisors. These actual percentages have not been identified as of yet. However, prior to this final contract going to the EMS agency board, those percentages will be nailed down. There's some research that the agency is doing to come up with appropriate percentages of increase for each tier, and that research hasn't been completed yet. We also came away with the recommendation of a written dispatch agreement, which allows the providers 90 days after the July 1st execution date to enter into that dispatch agreement with the Sheriff's Department. So the final approval process is what we're doing right now. We're presenting to you all today. The next step is that the EMS Agency Board of Directors will review the contract revision and make the decision whether to accept the new contract, and then the new agreement would be effective on July 1st. The recommendations at this point of the EMS agency and of the Emergency Medical Services Oversight Committee to the board is to renew the ambulance providers agreements for an additional 5 years and to approve the revised agreements for the period of July 1 through June 30th, 2015, which sounds like a really long time, but I'll tell you the past 5 years has flown by. And now, as we promised, there's room for questions, comments, etc.
Do any of the board members have any questions or comments? Mr. Tuffanelli?
Well, one of my questions was answered on the previous slide. But I'm looking at your appendix B that explains the language changes. And I just have a couple questions. Section 6.11 says deleted section. Language was specific to the first agreement. And that section says contractors shall ensure that the percentage of scheduled full-time field personnel is never reduced by more than 10% compared to the percentage of full-time personnel described in contracting proposal. Any deviation from this percentage may only be permitted upon approval by the agency. Why are we deleting that in full instead of just changing that language?
Sure. That change was removed from the contract because they are contractually obligated to meet a response time compliance time. And they, being ambulance providers, are responsible for staffing the units and having sufficient units on the road to make sure that they are able to meet the response time compliance requirements as outlined in the contract. And also because of the changes in the economy, call volume has dropped from the beginning of when these agreements were first began 5 years ago. And so for all of those reasons, that language is taken out of the contract.
So you think with their response time requirements and the 9% that they're going to be staffing in order to meet those levels is the reason why that was taken out. Section 14.2, which is the one talking about rate increases, and this is the one that one of my questions was answered by the slide, that by the time it comes to the Mountain Valley Board, that those percentages will be presented again in April, on April 14. One thing I would like to see in the language, though, is it doesn't state in here that this board would be made aware of any increases that would occur. And I would like to see language that we're made aware of it.
You like in tier one.
In tier one, any changes whatsoever, in tier one or tier two, that at least something comes to this board and we're made aware of it.
So it would be nice to be made aware of that before the change. Not before, not after the fact. So if we have some
And then on 17.9, we deleted that section where it says contractor shall achieve and maintain for the life of this agreement commission on accreditation of ambulance services. And it says within the 3 years of execution of this agreement. Why are we not just striking within 3 years of this execution of this agreement and leaving the remainder of that verbiage in there?
This is the CAS accreditation. Yes. Again, the issue we had in the initial contract that they would meet this standard of CAS accreditation. When they went through the process, they had met all the terms except for the communication portion of that, and they would not even come out here to do the evaluation because of the process with the infrastructure of communication within the county. And for instance, there are places in the county where you just can't get out by radio communication, the handheld, and that's a requirement of CAS that you can. And so they wouldn't even come out to do the evaluation based upon that component not being complete. So for us to require them to have that without them having the ability to fix the communication issue really was unfair. So that was removed. But again, I think having it in there for the first year, they went basically through the entire evaluation process of all the components and make sure that they met those. So I think it certainly it had a positive effect.
Okay. That concludes all the questions I had.
Mr. Thomas?
I think most of my concerns have been satisfied here. It's a little confusing to me about this language that gives some extended length of time to work out a contract with the sheriff's dispatch. I attended a couple of meetings where it was verbalized, a number of us verbalized that our concerns that the sheriff's dispatch should always know what the resources are in the county at any given time, and without specific language in the agreement with the sheriff's department that would set my mind at ease about that. I'm still not convinced that when the call comes into the sheriff's dispatch center, that the dispatcher knows by looking on a magnetic board or something where the resources are parked at that particular moment. So can you assure me that that is going to take place?
Yes, this doesn't change the way that dispatch is done, or really the issue that we had in the initial contract was that they have that they negotiate a fee with dispatch for those dispatch services. Because prior to us going through the RFP process, the ambulance providers, and we had multiple providers in the county call, none of them paid for those services at all. So it really was the standard for dispatch is set. This was really in terms of negotiating an amount, and that was set in the first agreement. But at this point, in the second agreement, we're asking them to renegotiate that. And if you recall, in the original language that we had worked out, is that they would have to have that in place before this agreement went into place. However, there was some concern about that if it wasn't done, that we can go live as of July 1st and give them 90 days to complete that agreement. In terms of the dispatch center knowing where all the ambulances are, they do have GPS, and they definitely know, and that really has nothing to do with the contract.
I have no further questions for these folks. I do want to ask our chief of Copperopolis whether all your concerns have been met with this proposed contract.
They have,
and why don't you come up with that?
Keith Cantrell with the Copperopolis Fire Department. They have been met, and we are currently under negotiation with ALA to clean up our three-way agreement, our mutual agreement, which is really something that was identified after we initiated our ALS first responder agreement. And that's really the biggest area that we need to work on right now. Every fire chief would love to have an ambulance in their fire district, but that's just not reality. So our community stepped up and decided that approving this ALS, or excuse me, the ALS agreement, I should say, is a way to fill that void right now.
Okay, well, if you're happy, I guess I'm happy.
Okay.
Thank you very much, Steve.
Mr. Triumph.
Well, Gary's happy on it. One
Not happy.
comment you made is that the call volume was down significantly, and you attributed that to being a bad economy. I'm puzzled by that relationship. Why would the economy have anything to do with the medical emergency and the calling of an ambulance?
Several things. Probably you've seen your tourism dollars are down. They're not seeing as many folks coming up and traveling to this area. And also people are not as enthusiastic, if you will, about calling 911 to get an ambulance if they are suffering some economic issues because of the cost of either being transported by an ambulance or being taken to an emergency department at a hospital. Industry-wide.
Well, they're not going to call an ambulance, and they're not going to go to the emergency room.
Or they don't. Oftentimes they will drive to like a physician or an urgent care center, or they will self-transport to an emergency department if that's the case. But industry-wide, we've seen a drop off in ambulance calls.
You did all these percentiles up here. What is sort of, if you did the 90th percentile, what is sort of an average cost for being transported to a hospital by an ambulance in Calaveras County?
I would have to defer that to one of the providers because we don't bill, so I don't have an average cost. When did we jump? Go ahead.
Good morning. Alan McCain with American Legion Ambulance. I'm not really sure what you're talking about, average cost. Average cost per transport for the American Legion Ambulance is about $627 per transport.
And that,
If you look at-
that's countywide, that's out of the community. I'm assuming it's a lot less if you live in a community center than it is if you live outside of the community center and you're out
That's-
in a rural area. Is that an accurate?
Correct.
Okay.
Our average cost is $627.
That's it.
But you have to understand that there are government-regulated accounts, as in Medi-Cal and Medicare and Workman's Comp, that we can only charge X amount of dollars. So on
the
Medi-Cal,
average cost is $626, but you don't get paid by everybody.
correct.
That's was going to be my next question.
Correct.
What that 626 is the average cost, not the average return. The average cost. What is basically the average return? Because there has to be sort of an allowance for people that don't have any money, so they don't pay at all, and you have to respond. And now you're telling me there's a whole bunch of government rules that say you can't charge people that the government deem whatever, that you can't charge them.
Correct.
So what is the average return, and then that deficit, how is that covered?
Average returns per ambulance trip,
Right.
if you're talking about private pay or private insurance,
Oh, just yours. I mean, your average cost is $626 an ambulance. What is your
That's-
average return?
our average return is $627 per run.
Well, that's your average
If you look
return.
at Medi-Cal, we average $120 from Medi-Cal. If you look at Medicare, we average $400 from Medicare. If you look at private insurance, we average about $1,400 from private insurance.
Even though your cost is $620. So the people that are paying the private insurance, that everybody's blasting, the insurance rates are too high, but one of the reasons they're too high is because they're subsidizing the rest of the system.
Correct.
Is that not accurate?
We have to cost shift to private insurances to make up for government. That is how healthcare got into trouble.
So those of us that for those out there that are paying private insurance, they're being halved.
Correct.
Because they're paying a very inflated insurance rate to cross-subsidize.
Our employee insurance through Blue Cross just went up 41%. We are currently looking for a different provider.
But so how do you cover the shortfall? The cost $626. I'm lost now. Is it $626 is your average return or your average cost for all your ambulance runs in a year's time?
It's our average return.
Okay, what is your average cost? What does it cost you to do that? $626 also? So that
Pretty close.
And then you're just cross-subsidizing within the system to break even?
Yes. American Legion Ambulance being a nonprofit organization, that's what we do is look at breaking even every year. So normally when we have
But you break even by just taking whatever your deficit is and adding it to the private insurance cost. That's where you're breaking even to cover all the deficits. Is that correct?
correct, when we do a rate increase, that rate increase only affects the private commercial payers because the government is only going to pay you what they want to pay you.
Well, what happens with the healthcare system when the government takes over and the government says this is the rate for everybody?
Tom,
Because
I don't think that.
I want to know where the
healthcare
system goes.
reform is very scary to me.
I mean, obviously we have a huge gap.
Yes.
That's
There is a
beyond the
problem
realm
and
of-
it needs to be fixed.
No, it isn't beyond.
Tom, it is
It's a
beyond.
question of healthcare and where we're going to go. And this is our ambulance service. And the healthcare just changed when Obama signed it today. I don't know if he signed it yet, but he's going to sign it today. And we better have some idea of how that affects us and how we're going to address those effects. It certainly is, in my opinion, libertarian. I guess that all the cost subsidies I am concerned about. And when you're charging $150 or $200 because of the government rate, and you're charging $1,400 because somebody is responsible enough to provide insurance for themselves. They're not providing insurance for themselves, they're providing insurance. If it's $600, then they're paying $800 to pay.
I agree 100% with you.
For 4 other people and their ambulance costs.
I agree.
Thank you.
Thank you.
You can tell that the chair is the Democrat.
I'm not partisan office. Try on.
Brian Dixon, Assistant Fire Chief of Fast Fire District. We use a little bit different model to put our resources on the street. We use what we call all-risk responders. Fire suppression personnel are also cross-staffed and cross-trained to provide advanced life support services. We use 3 first response paramedic engine companies and have the capability to put 5 advanced life support transport units on the street. We do that through 2 special taxes that our voters impose upon themselves, and that provides us with, can I say, the standby workforce. Yes, we do bill out for every response we go to, but basically because of our 2 special taxes that were put in place, the assessment fees by the citizens, we accept assignment. So no one pays out of pocket for any ambulance service provided. You can associate yourself with a property in the Fast Fire District. If you're renting for a weekly basis a rental home and you have a medical incident at that home, then your insurance company gets charged. Our rates are exactly the same as American Legion's, and as far as what we get from Medicare, what we get from Medi-Cal, what we get from private insurance payers is what we get. But unfortunately, we have these special taxes in place that allow us to staff our paramedic engines and allow staff our paramedic transport units. Also, we use callback personnel. We use contractors, doctors, lawyers, Indian chiefs, butchers, bakers, candlestick makers, all people who come down and do volunteers. And we put them on the clock when we staff our 3rd, 4th, and 5th transport units. And it's not only does it provide us with better emergency medical services response, it also improves our public safety infrastructure, being that we have a large wildland fire and we have to call back additional personnel because additional staff for that. So we've been very successful using what I call the public safety model or the all-risk model. But it took us 11 years to get there. And I think our agency will manage to survive the healthcare changes that are coming through. But it's the basic question you have to ask yourself is the provision of providing pre-hospital emergency medical services a public safety responsibility, or is it a public health responsibility? And if it's a public health responsibility, then we fall into the healthcare payer process. So our community looks upon it as a public safety responsibility and assess themselves and put the infrastructure in place to make sure they have the services. And that's the difference between us and a private provider.
Thank you.
Any questions?
Good job, Ryan.
I have a question on the response time. We talked average, but I just happen to be looking at the South Zone. The 90th percentile is 20 minutes. The average is 11.2. When we look at performance evaluation, we have to look at the 90th percentile.
That's exactly.
That's how all the problems came up.
Right. There was a lot of misconception. People were looking at averages, and contractually, we get industry-wide, you look at 90th percentile as the compliance standard, and contracts are written to meet the 90th percentile compliance standard. What we made the decision to do was to show folks at the public hearing and then at the MSOC meeting what their averages were, because there was a lot of misconception out there, and we wanted to talk about the 90th percentile and then show what their average times actually were.
But average times are meaningless.
Correct. They don't matter.
They don't matter. So I mean, by putting it out there, I just didn't want it to be something that was confusing, because that was not based performance evaluation.
No performance standards
not
based upon those numbers. No.
Okay, thank you. One issue I have is with the East End, with Ebbets Pass Fire Department, because of the circumstances of that. And I know we're going to be putting, if we haven't already, the contract with them together, separate from American Legion. And I know we had to go through some concerns this time. What can we do in the next 5 years to keep this renewal process for them separate from what might be occurring with American Legion and whoever it might be for the north end, south end?
The short answer, nothing. And the reason being is because by the county ordinance and by state interpretation of statute, that we can only go 10 years on an exclusive operating competitive bid process before it has to go out to bid again. So at the end of this 5-year period, we're going to have to go out to bid in all of those zones again. And so it'll be an open process just like we did the last time.
Just seems a little bureaucratic to have to do that in its past case as long as they perform as required by the contract.
We agree. And as a matter of fact, the statute that creates the possibility of creating exclusive operating areas says that if you go out to bid, you have to rebid that zone periodically. And so there was no definition of what periodic meant for quite a long period of time. Since that time, the Stadium Authority has come out with, has opined that the periodic means 10 years. And we've been fighting that for some period of time because, again, in counties like this, I mean, to have the capital expenditure and 10 years, Peter said it, this goes by very quickly. It really does. So I think it's unrealistic, but right now we are limited to the 10-year window.
It's not only unrealistic, it's very costly to do this in terms of just. All right.
Well, maybe 5 years from now, things change.
We're going to hope so too. But it brings up another point: is that this issue. It takes about 2 years to go through an RFP process. So we're going to be coming around with this issue before too long. I mean, we're looking at 3 years from now. We'll be well into this again.
So, here is our representative. If there was a way that we could lobby, request somehow for those exceptions, because it is an expensive process, time consuming to do it, where as long as the performance is there, we know what the outcome is going to be.
This is actually an opportune time for that, and especially if you have a CSAC meeting or something coming up.
I do this week.
The document that the state has had lots of opinions on exclusive operating areas that they've put out over the past 20 years. But there's been no collection of these, and so they are going through the process right now of creating a guidance manual of exclusive operating areas. That is in draft form right now. This 10 years is in there. We have fought this thing for about 1.5 years, and if we could get the counties on board with this one to put some pressure on the Stadium Authority, we would love to have that support.
I mean, I think it should be reviewed. I'm not saying there should be oversight and review so the public know what they're getting, but to go through that RFP process.
Before the 10-year came down from the Stadium Authority, periodic, we always had that interpreted at the local level and, based upon the circumstances at the local level.
Well, maybe if it's passed by a district would like to bid on the one from the south. I would like to open this up to the public. Does any member of the public have any comments they'd like to make on this? I want to bring it back to the board. You are asking us to accept this report and recommendation. It's not something that the Board of Supervisors in essence approved. You want to know, are there any issues that we might have? Because there's no formal action for us to take. So I guess I'm going to just poll the board and see if there's any direction to give supervisors tough on how when he goes to the EMS. Tom, are you fine?
I'm all right.
Russ?
I'm very pleased with the outcome here, and I want to express my appreciation to the members of the MSOC committee and very hard-working folks, and I appreciate your effort. I know Peter, you probably took a day off work to be here today.